From Pand Health, I'm Rachel Wexler. Welcome to our show, The Mind Exposed. Every month, we bring to you national experts to explore mental illness and mental wellness. We hope you enjoy this month's episode.
Hi and welcome. My name is Kyle Menschel, and I'm a lead clinician with Pand Health. Today, I'm here with Dr. Emily Owens from Cognitive Behavioral Associates. Dr. Owens, thanks so much for coming on this podcast with us.
Thanks for having me. I'm
Absolutely.
excited to be here and chat.
Yeah. So just, I guess, before we launch into today's topic, which will be kind of this overlap between OCD or obsessive-compulsive symptoms and psychosis as a whole, why don't you tell us a little bit about your practice?
Yeah. So I'm a psychologist at Cognitive Behavior Associates, which is a small private practice here in Los Angeles. And we do, as the name implies, very cognitive behavioral focused treatments. And my specialization is with psychosis. Under that umbrella, I would put things like schizophrenia, bipolar disorder, etc. And then also I do a lot of work with OCD.
Okay, so you see that overlap firsthand.
Yes.
Okay.
quite a lot.
Yeah?
Yeah.
About how often would you say you see it?
I mean, I guess I have obviously like a selected sample. So I would say with the people that I see that have psychosis, I would say probably about like half of them have some degree of OC, obsessive compulsive type trait to them. So we can talk about like clarifying. We'll just say this up front. I do not really like diagnostic categories because of what we're talking about today, which is like there is so much overlap and the categories don't really work very cleanly. But yeah, we can kind of talk about the specifics of when is it OCD or when is it maybe just a trait, I guess.
Yeah, absolutely. And I am completely on board with this idea of these diagnostic categories become something that from maybe a client perspective, a family perspective, I understand the importance of it. I understand that it can be tethered to one's identity, and receiving a diagnosis can be a really, marked point of somene's life.
Yes.
You then go through the insurance. And, there's all the F codes that relate. But then from the clinical side, you and I, it really is just this huge gray area.
Yes.
Because I think in my practice as well, maybe not 50%, I'd say closer to like 30 or so, but do experience a lot of these obsessive compulsive symptoms, even though I would say a fraction, very, very small amount, ever enter or leave my office with an OCD diagnosis.
Yeah.
But we're still doing the same stuff.
Yeah. There's definitely a lot of overlap, and I guess what I just want, because I experience this a lot too from families and caregivers and clients themselves, that they're like, I want a diagnosis, and I'm happy to do that. And I also like understand where that comes from. And I think just historically, it helps people to understand medical diagnoses come from like doing science and like looking under a microscope and seeing like, here's this bacteria and then here's this antibiotic.
I use this exact
right?
analogy
And
all the
like,
time. Yeah.
That antibiotic kills this bacteria. And so now we can like call this thing, and it's very clear. And like we have this whole process that we understand for like how X causes Y. But when it comes to mental health diagnoses and things, like the way we got these diagnoses is the DSM-3 task force from like, I don't remember the year, it was like 1970 something. Okay. So it's essentially like 20 white people got in a room and sat down. Actually, and we're like, I
don't think I know the
that's
history
the DSM-3 task force is where we got like the first version of the DSM as it is today, right? And then from there, DSM-4 or 5, they're just iterations of that. So that's like the baseline where we started. And now everything is like adjusting from that original position. So that's why I'm like, let's not get like in over our heads about like the categories here, because they're coming from a place of like, accidents. Like, oh, we accidentally found that this medication that we thought was going to help, heart disease actually turns out is helping people with depression. And so again, we're just so unclear on the cause and the whys and the hows when it comes to mental health things. And I think that's really, really, really important for people to understand. And it actually goes into what I see is like the big reason for this overlap of psychosis and OCD, which is uncertainty. Okay, so that's like the kind of like psychological term, or what we would see as that's at the core of OCD. It's at the core of a lot of anxiety disorders, but especially OCD. OCD is essentially a reaction to I don't want to say failure, but a severe discomfort with uncertainty. And so the like classic example, I'll use a classic example of OCD. I want to get into like other subtypes of OCD too, because the classic examples are like not really how they look
similar.
In real life.
I mean, similar for psychosis or schizophrenia. There's
the
classic example. And yet that's actually most frequently not who walks through my door. But continue. So OCD.
Well, so let me use a not classic example.
Oh, okay.
So I was going to just use contamination, but we can use something a little bit weirder. Like weird, I mean like not classic. So one subtype of OCD that is obviously very hard for people to deal with is it's called scrupulosity OCD. That term means like it's basically comes from religion. So it's people who obsess over religion or morality, and they greatly fear doing something immoral or against their religion, and then they do a bunch of compulsions to try to like correct that.
So how does that separate from just like a classic Catholic guilt?
Well, yeah, I mean, obviously there's a lot of overlap. I mean, OCD, you would be seeing somebody like very excessively doing things, right?
Okay.
So like we would see people, and I've had clients do this, like going to confession multiple times a day, or on the moral side, really just constantly like beating themselves up over extremely minor things. Okay. And so the core of all of that, it comes from uncertainty. There's a not knowing. Did I do something wrong? Did I maybe mess this up a little bit? Did I maybe hurt that person? Did I maybe not have pure intentions? Is also like, were my intentions pure behind this? Did I lie? There's a question mark there. And people with OCD, that question mark is like intolerable to them. So they do all of these compulsions to try to feel, it's all feeling based. It's the compulsions help them feel temporarily okay. So if you take that idea of like uncertainty, of not knowing, and you think about psychosis, where we're dealing with things like voices, hearing voices, seeing things, feeling things, having experiences that can't be explained, that other people aren't having, you can see there's like a very high degree of uncertainty that these people have to deal with, right? Constant. And on top of that, we as a medical scientific community, we also don't have clear answers for them. Why did this happen? Is this coming from a neurochemical imbalance? Is it because you took this drug one time? Is it because you smoked weed this one time? Like, we don't have answers to any of these questions, yet these people are having these very intense aversive experiences. And so that's my kind of how I see it. Is like the people with psychosis are dealing with such a high degree of uncertainty at all times that it makes sense that a lot of them would then have a kind of an obsessive compulsive or like a OCD type way to try to deal with that uncertainty.
That makes sense.
Yeah.
And then, I mean, I'm also curious about how in a classic, like you're saying, OCD example, there is this concern that a decision you make will incongruently lead to a catastrophic event. And in my experience, working with folks that have experienced OCD, they know that's not going to happen, and yet they can't help the discomfort, like you're putting it. How does that separate, though, from what we might call within working with psychosis a delusion?
Yeah, great question. So the simple way of thinking about it, and I would say this works in about 95% of cases,
Okay.
is that, well, just as you said, people with OCD have some awareness that what they're doing is not necessary. And that's actually part of what makes OCD so uncomfortable for people, is that they're saying, like, I know this is unreasonable, but I can't stop.
Against their own view of themselves and their view of reality.
Yes, but I can't stop. However, there are people with OCD who don't have that awareness, and we call that, and this is where these diagnostic categories for me, like, kind of fall apart, because we call that OCD without insight. They don't have insight into that thing we just talked about. But that can still be OCD.
And not psychosis.
Right? But then psychosis is like, okay, I have, paranoia that, some government agency is tracking me and following me and has microphones in my house and da-da-da. And I can be doing a bunch of checking behaviors that kind of look OCD around that. I can be constantly checking the locks. I can be constantly looking out the windows. And I can have no insight into that being unreasonable, but that in that case would kind of fall more on the psychosis spectrum of things. So you can see how, it is murky, but again, most of the time there is a way to tell, and that is the way to tell is there some insight? And also there's this term like ego syntonic versus ego dystonic, right? So it's like, does it match how I think about myself or not? And so OCD does not match how I think about myself. Like I generally think I'm like an okay person, but I'm having all these experiences and all these feelings telling me that I've done something horribly wrong, right? It's not matching up. Whereas with psychosis, there is more of this like often like pervasive feeling that, no, this is me, which is obviously very sad and tough to deal with.
Yeah. I mean, so are there, on the one hand, we're talking about how they are so similar in certain ways, and from a clinical standpoint, it's not too different.
Yeah.
Now, it's actually very different, yada yada, but when we're talking about the obsessive-compulsive symptom itself, that when we target them, whether I'm working with someone who has schizoaffective disorder or I'm working with someone with OCD, if they both are presenting with an obsessive-compulsive symptom, I'm kind of going to use roughly the same type of behavioral therapy.
Totally.
Right? Is there a danger, however, in confusing the two?
Yeah, I would say if you are dealing with something that is probably more psychotic and you're only treating it like it's OCD, you're probably missing a big piece of the picture. And also from a medication standpoint, neither of us are psychiatrists, but we can just kind of say, again, from a very, very basic, oversimplified perspective, the meds that work better for OCD are serotonergic in nature, and the meds that work better for psychosis are dopaminergic in nature. So if you can be missing a lot, I think, if you're only calling something OCD when it might have some more complexity to it.
And very rarely, and although it's possible, very rarely in my experience when working with someone who has, a thought disorder, which would be psychosis, is their only symptom an obsessive-compulsive one.
Totally.
And so by only targeting that, I'm losing out on supporting all of the other things, the disorganized thinking you were mentioning earlier before, right?
Yeah.
That alone needs a lot of compensatory cognitive support that just wouldn't really apply to a cut and dry case of OCD.
Exactly.
However, and I know you and I have talked a little bit about this outside of this setting, we have experienced that for a lot of folks and a lot of families, it's easier, or it appears to be easier, to accept a diagnosis of OCD than it is to accept a diagnosis of, let's say, schizophrenia.
Totally. Yeah. And that's the stigma of psychosis. And that's just something that like always makes me so sad to think about and talk about, because it's just, it's perpetuated. The stigma of psychosis is perpetuated by the medical community, by the mental health community. There's still this sense that like people with psychosis are like a lost cause, or like all they can do is take medication and that's the only thing you can do for them. And it just, nothing could be further from the truth. And it's very sad to me that this still exists, but it does exist. And so I do understand totally people's hesitancy behind accepting a diagnosis of psychosis. And I myself am like hesitant to give that diagnosis sometimes because I know the weight of stigma that comes with it. And so, yeah, we're kind of like in this position of, is this doing harm? Like, am I doing harm to somebody by telling them this? But also, if I don't tell them this, then they're not potentially going to have the accurate information that they need.
Yeah, not the right medication, not the right type of treatment. But it is so easy for someone to look at, intrusive thoughts, right? That's a common OCD symptom.
Yes.
And I could see a world in which hearing a voice or having thoughts that feel, maybe not a voice, but feel foreign to the experiencer could be like, oh, wait, maybe this is more of an intrusive thought.
Totally.
And yeah, I guess it is technically intrusive. Totally. But it can lead down a path that might not provide the individual the best care, the most appropriate care that they need there. But then that kind of takes us into, because these two things are so overlapping.
Yeah.
Should there be a diagnosis that addresses how overlapping they are?
Yeah, so there's like a proposal that I doubt will ever go anywhere, but there's a proposal for a term called schizo-obsessive disorder. And I don't remember any of the numbers, but because there is a high degree of overlap of people with psychosis that also have OCD. Yeah, this has been proposed, and essentially to meet this criteria, which it's not a real diagnosis yet, but it would mean you start with kind of a baseline of something like schizophrenia, schizoaffective. So you start with a psychotic disorder.
So it does not start with an obsessive-compulsive.
Right. So it's more in the realm of, it would fall under like a schizophrenia type category. So you would have that, and then within your experience of having schizophrenia, you also have a diagnosis of OCD that is not entirely within the context of your psychosis. So again, like a lot of people, as you're saying, have intrusive thoughts with psychosis. A lot of people will, be hearing a voice and will do a lot of like checking behaviors or have some kind of like rituals around feeling safe when they have paranoia. That wouldn't qualify because that's all entirely within the context of a psychotic presentation. So you would have to have some other entirely separate OCD presentation, like contamination, I'm washing my hands, 20 times a day or 20 times an hour. All the other ways that OCD can look.
So, you take an antipsychotic, you're taking Zyprexa. Your psychosis, doesn't completely resolve, but it
Gets
you
better,
more functioning. It gets a lot better. But the obsessive-compulsive stuff doesn't necessarily. That's when it would kind of fall into this theorized.
Yeah, I think that's a good example of it. And I've seen it with people that they'll have and it does sometimes interact with like a voice. If they have an ongoing experience of hearing voices, like everything interacts with that. Yeah. So it's hard to entirely separate. But like I've had people with like driving OCD where, or it's called like hit and run OCD, where when you're driving, any bump in the road, they feel, do you know about this?
No, I don't.
Okay. I was like, the look you're getting is like, what? Yeah, this time OCD gets really, really weird. It has very, very weird little niche subtypes. So hit and run OCD is when you're driving and you hit any kind of bump in the road, the intrusive thought is, I just hit a person or an animal or something. A child, exactly. And I'm going to like get home and see it on the news and the cops are going to come after me and I'm going to like go to jail forever. And so they'll like loop their car many times to check to see if they did hit something. They'll like pull over, they'll get out of the car, and then they'll like go home and they'll watch the news obsessively to see like, was there a hit and run? Was somebody, was a child killed where I drove? Yeah.
Oh, God,
Yeah,
that is
so
stressful.
I've just introduced a new realm of uncertainty to
Yeah,
you that
oh
you
gosh,
were
now
never
I'm gonna
aware
have
of.
to, yeah.
Yeah, this is what OCD does. It's like these things are all there is always this uncertainty always exists, but OCD just makes people like so incredibly aware of it that they're like, I can't handle that. I can't handle that uncertainty. And of course, like, yeah, that would be the worst thing ever to happen, but it happens, and and we
Wow.
have to live with the uncertainty, and we have to learn. So the treatment would be to practice driving without circling around, without checking, without getting out, no looking at the news, right? So we would like design a whole treatment.
So this would be exposure response prevention.
With response prevention.
Got
correct.
it.
Yeah.
And so does that effective for, I mean, and this is kind of a rhetorical question because I work with psychosis, but in your experience, is that effective also for folks experiencing obsessive compulsive symptoms in psychosis?
Yes, totally. And yeah, I think when you do see that overlap, like introducing this idea of uncertainty, and this is something that we all are constantly living with. We're just not aware of it. And I'll tell people with psychosis, I'm like, genuinely, the actual truth is, or I'm sorry, people with OCD and psychosis, either or. The truth is everyone else is delusionally confident that these things aren't going to happen to them, right? I have a delusional level of confidence that when I wash my hands for 10 seconds, I don't have like some bacteria that's going to get me sick. Or I have a delusional level of confidence that when I drove here and I hit 7 potholes, that none of those were animals. Because it's literally just, I don't have a feeling telling me that any of those things happened. Mm-hmm. And so I don't worry about it. But I feel, I could tell you, like, I'm 100% certain I didn't hit an animal on the way here. But that's, I don't know that for sure. Mm-hmm. That's just my feeling is telling me that.
Wow. Yeah.
Right?
Oh, that's, I mean, it honestly reminds me of a lot of the same work I would do for folks that are experiencing psychosis.
Yeah.
That don't have any obsessive compulsive kind of symptoms. It's just this idea, and we use a lot of at hand metacognitive training.
Yes, yeah,
metacognitive
that's
training
huge.
is
Yeah.
all about
huge
being able to identify and consciously use objective indicators when making guesses.
Yes.
And so that our confidence is dialed in.
Yeah.
And almost without fail, everyone who starts out in an MCT course with us, they either have way too high confidence, like they're like, oh, I'm 100% confident that person is actually, here from the electric company, and you're like, it's just a photo of a face.
Yeah.
Like, how would you get this whole
this?
story?
Yeah.
I remember I once a long time ago was showing, there's this exercise in MCT in which you show paintings, classical, like romantic era European paintings. And you are given 4 options for what the title of the painting is. Okay. One of them is true. This is not up for debate, right? And you ask folks, which one do you think it is? Now, you use context clues in the paintings, and then you identify what your confidence value would be. So, like, I'm 40% sure it's this. It seems like an appropriate amount. You've never seen this painting before. 40% indicates that you think it's, if you have a 1 in 4 shot, it's above a 25%, right?
Yeah.
So, you're feeling pretty good about it. But you're also like, at the end of the day, I don't really know. 40%.
Right, yeah.
But then I remember I worked with this one individual who came in and was like, it's 100% that one. And you're like, okay, 100%. Why? And then had a whole narrative. Yeah. It was like, well, she's cheating on him. And he's coming home way too late from work, and she just can't take it anymore. So during the day, she heads out, and I'm like, what on earth? Where is this? He's like, I know it. And then you click the button, and it shows, and it's like, that was incorrect. And I go, was 100% really warranted? He said, I had the clues. Like, you're right. Clues. You did have the clues. Yeah. But it's 100% saying I have the clues. If you had $100...
Yes.
Would you put $100 on that, or would you even put at least $99? So no matter what, you still had $1 left over in case you lost it. Through our work together, he eventually got to a point where he was answering much more balanced questions.
Yes.
Now, I think the overlap here between OCD and psychosis is a lot of this does have to do with our ability to guess and
Yes.
just tolerate guesses.
Exactly.
Because you're right. I don't 100% know that I didn't unfortunately hit like a squirrel on the way over here.
Mm-hmm.
I'm 95%. I'm actually 98% sure I didn't.
I'd give it a solid 99.
Yeah, even 99. However, you are right. There is that possibility. However, for myself, in this particular instance, and I'm sure based on all of our unique experiences and upbringings and traumas or whatever, we have ones that we're a little more sensitive to without meeting diagnostic criteria. But with this one, I'm pretty positive I didn't hit an animal. But a lot of what I'm also doing when it comes to psychosis is the same deal, is how confident are we that we're going to fail at this class that we just enrolled in,
Right.
that you've already decided isn't going to work.
Yep.
Oh, you've decided it's not going to work because the teacher is actually horribly racist. They might be. How
Right.
confident are you that they're horribly racist and that they're targeting you specifically? And, you know, I don't know, 4 out of 5 times they provide some examples and we go, let's see what the alternative explanations can be.
Exactly.
And then 1 out of 5
Yep.
times you go, oh yeah, that teacher sounds racist.
Yeah.
Yeah,
Yeah.
like,
Sometimes
you are
like,
onto
okay.
something actually.
And then if that is the case, then how do we manage that? How do we tolerate it? How do we problem solve? Like, yeah, if I did hit a squirrel on the way over here, what do I do, right? It's not impossible that this happened. Yeah, so there is, like, already a lot of overlap just in what you're saying. I do that exact same thing with my OCD clients and my psychosis clients of, like, if you had to make a bet, and I would say, like, you have to bet all of the money that in your savings account.
We even have these like poker chips that I ended up with that, like, or we used to use pretzels where it's like, here is this amount.
Yeah,
it's I have the bank here. I will
have to
double your money if you're correct.
Yeah.
But yeah.
Yeah, and so that gets people out of this, like, I think that emotional place of, like, but it feels this way, and again, always OCD is always about a feeling. It disguises itself as a logical problem, but it's a pure emotion-based problem, or emotion-based disorder. But yeah, so there's these strategies, these, like, cognitive strategies that we can use to kind of get people out of that feeling. I'm basing my decision based on how something feels. And we see that a lot with, like, delusions too, right? It feels this way, therefore it must be true.
Yeah.
And that's kind of my only decision-making factor. So getting people to use other, context clues, facts, evidence, like, what else can we use to either kind of diminish that idea or build it up. Yeah,
absolutely. It's that dialing it in. And so it goes back to, there is an overlap.
Yeah.
And there's also not at the same time.
Right. There's totally an overlap. And again, I think like, I think from what we're saying, like, if there is a degree of psychosis, then you need, as a caregiver, family member, you need to be seeing treatment providers who have expertise in that. Even if OCD is also present, if there is some, even like a question or an idea that, well, what if this is more than OCD? I would say, like, go to somebody who can actually answer that question for you.
Absolutely.
And could also treat the either or.
Absolutely.
Yeah.
And I think you are one of those providers. Absolutely.
Yeah, and then, I mean, I wish there were more of us.
Me
like,
too.
I
do too. Well, and with that, thank you so much, Dr. Owens, for joining us today. Would you like to take a moment to plug your amazing practice?
Yeah, sure. I'm at Cognitive Behavior Associates. We're in Beverly Hills. And so that's our website, business name, all of the above. And we do, obviously we have clinicians that do excellent work. We also have a training arm called Cognitive Behavior Therapy Institute that does webinars. So we just did do a webinar on Scrupulosity OCD. It was super fun and interesting. So you can find all that at our website.
Excellent. Well, once again, I'm Kyle Menschel with Pand Health, and thank you so much for coming.
Thanks for having me.
Thank you for joining Pand Health's The Mind Exposed. You can watch us on YouTube or listen to us on Spotify or anywhere you get your podcasts. See you next time.